It's my great pleasure to introduce Professor Mirko D'Onofrio from Verona, Italy, and he will talk about fusion imaging and interventional procedures. So please, Mirko.
Thank you, Adrian. Thank you, Christian, for your introduction. So I will speak about fusion imaging, yes, and interventional procedure dedicated to the pancreas. First of all, let me say that fusion imaging is really a new image techniques. We can use CT or MRI from one side, and to the other side we can use normally conventional ultrasound, but why not also Doppler techniques? We can add contrast ultrasound during our fusion imaging. So is a little bit more complex, all these image methods together, but this is to reach a higher level of our investigations. And but it's important, in my opinion, to understand where we want to add all these techniques together. So it's important to understand which problem we want to solve by using fusion. So I designed this presentation speaking first about interventional procedure to the pancreas, obviously using ultrasound. And this is an interesting point because we know that we have endoscopic ultrasound first for sure, but in radiology, I am a radiologist in radiological departments. Normally, the easy way or most used is CT. Unfortunately, CT is not always good to reach and to obtain the correct direction to arrive to lesions in the liver and in the pancreas, you know. So we are using more and more, and now is quite the only image technique that we use to guide interventional procedure percutaneously to the pancreas. So I will show you a standard procedure, and then we will move to a new application, new procedure that we need to know. And so among these new application, I will speak also about the fusion imaging. Standard one, we have diagnostic procedure, in example, FNA and biopsy that can be guided to the pancreas, to pancreatic mass, obviously, by using ultrasound with percutaneous approach. And in this case, we performed an example in one morning. We can perform 10 procedures with the pathologist together with us, so to have the final diagnosis for 10 patients in one morning. And really, normally in everyday clinical practice, we don't feel the need of the use of fusion imaging if the lesion is well visible and well reachable by using ultrasound with a percutaneous approach. I will not speak about drainage, but is in a hospital where you perform pancreatic surgery, you need to know how to put a catheter inside the drainage after operation. Why the use of ultrasound? We know that we can view dynamically the needle. We can add Doppler before the study to be sure that major vessels, especially the arterial one, will be avoided. Short time bomb procedure means that in one breath holding, we can go inside the lesion and then go out. This is very important for difficult reachable lesion, and we are using a technique that is for sure cheap in respect to CT, but however, the choice of image guidance is based on local expertise in every single centers. Just to remind that we are using sterile devices, and we can have the guidance put laterally to the probe or inside the probe, and we can reach the pancreas with the different angles. The angles is depending from the machine that we are using, and what is very important is to have the the probe, as you can see here, with a sterile position, and is also sterile the devices, but the devices needs to be free to change the caliper if you need to change from 20 gauge to 18 gauge, just to improve the materials that you will aspirate or biopsy. And so also this is guided from the pathologist. I mean, we can start with a fine needle aspiration and we can move to biopsy because the lesion seems to be a benign sample. Think about autoimmune pancreatitis. But if the cells are malignant, ductal adenocarcinoma, we can close the section, we can close the diagnosis, unfortunately, with a very easy aspiration with the patient in the room. So we can come back and we repeat the procedure if necessary. Just have also a hole on the needle that we can use. This is a true cut needle, you know, this kind of needle, but we prefer to start with a McGinney modified. It is more easy to use with one hand, and is more easy also to move inside the lesion for aspiration. So this is the situation before the aspiration to the biopsy. Our procedure, we are guiding the procedure with ultrasound. We are using multiparametric ultrasound. So in this case, Doppler, obviously, to be sure that the street that we are running, that we are using, is free of vessels. So we can reach the pancreatic body from the right on the left, in this case from the right, because we are the measure length of this lesion can be passed by with a needle. This is an example with this movie, how to reach a pancreatic head in the head of the pancreas. You can see the needle inside it is running after our application. This is the accuracy that we can have with these techniques. Generally speaking, this is a paper we published a few years before. So 98% of the accuracy is absolutely high, and this is due to the presence of our pathologists together with us. So coming to the recommendation from our EFSUMB guidelines, so unresectable, locally advanced pancreatic muscle should be evaluated for percutaneous ultrasound. It's fast procedure, is cheap, and the accuracy is absolutely good. If it's not visible, because we know that is not always the pancreas is visible, but we need to be skilled enough to try this approach. And so if is not visible, we do not need to try with multiparametric, because B mode is essential to guide the aspiration or biopsy to our pancreatic mass. What about the new applications and techniques? First of all, let me say that over and is improving the possibility to apply treatment to the pancreas, treatment to pancreatic cancer with a percutaneous approach. This kind of treatment is not a revolution. The revolution is the results of chemotherapy. So we have a very often, always more, and we are happy about that, a long survival, better survival owing to chemotherapy. So after 1 year, sometimes also 2 years, we can have also the situation unchanged and of a patient of a lesion that remain unresectable, unfortunately. So we have to do something more. This means that we can apply radiotherapy, but also local ablation nowadays is justified. And the percutaneous approach can be possible, and the use of ultrasound is sometimes more easy and sometimes also safe. Let me show you why. I prefer speaking about the minimally approach for ablation to divide the head, more complicated from an anatomical point of view, but so to approach endoscopically. But if you have a lesion in the body of the pancreas, as the one I showed you before, we can ablate this lesion with percutaneous approach by using ultrasound. The needle for ablation is absolutely near to the needle that normally we use from for the diagnosis, so aspiration and biopsy. And what about the imaging, the guidance? I mean, we can use CT, we can use ultrasound. Now, for this kind of technique, for this kind of procedure, I'd like to have more more imaging. I mean, more technique. More. I want to be more sure about what I am doing, because this means that I am inside the lesion. I start to burn. I start to ablate the lesion, and I want to be sure that I am in the correct position. So in this case, fusion imaging can help us. So can give us something more. And so this is an example of an ablation. Ablation performing percutaneously is a thermoablation. And as you can see, the technique is nowadays well known. We have to put the needle open perfectly inside the ductal adenocarcinoma. This means that we will do only a cytoreduction in respect to the liver. But you can see so the gas developing, and very often the ablation will cover the lesion quite completely, but from the inner portion, from the inside the lesion. And this is our series that now we are using this in everyday clinical practice. So fusion imaging in this case can give us something more. So in an example, in this case, you can see that the lesion is the body. We can put the needle for ablation. We can put the needle for biopsy for sure to have the diagnosis of this lesion. And with CT, we are more confident that we are running and we are using the right position, the right street to reach the lesion. And however, as you can see, there are some differences in respect to the liver, because as we heard from the previous presentation, compression is absolutely essential to better visualize the pancreas and to better reach the lesion for interventional procedure. So compressing, you will have differences. But however, what you will change is the position of the bowel, stomach, and so on, and not the retroperitoneal organs. So in this case, you can see a perfect correlation. This is a new application, a new techniques in fusion, that is the automatic synchronization. This is very important. With a few anatomical landmarks, you can have automatic synchronization, and this will reduce our timing for prepare the machine and prepare the system for the procedure. So we can, you know for sure about some very accurate phase and very accurate techniques and image methods, such as MRI for the liver, MRI with a late specific contrast agent. So we can have also fusion with these techniques, and the reply is, the answer is yes. So you can think about what is better for a patient in case you want to treat and to, or biopsy also, a lesion that is visible only with MRI. In a radiological congress, you will heard about the possibility to biopsy this lesion under MRI guidance, for sure. Yes, why not? But it's for sure more expensive. If you put MRI together with MRI, with the ultrasound, you can have a biopsy. You can prove the presence of a metastasis by adding contrast, and then you can have the biopsy and the treatment of this metastatic lesion. This is to the liver, but you can think about the, this contrast MRI can be fused with ultrasound for the pancreas, but also by using some sequence so famous like diffusion wave imaging. As in this case, you can see that the lesion is visible, and the viable portion, the high cellularity, so the viable portion of the metastasis can be punctured selectively. Coming back to the pancreas, so you can see that we can have a fusion imaging for the head of the pancreas with a dynamic, in this case, pancreatic phase of CT. We can add Doppler to be sure that we are avoiding viewing the confluence, the venous confluence, as in this case. Look in this case, how can be precise our fusion, the celiac trunk, and is perfectly superimposable. So you can see the lesion infiltrated the celiac trunk. So with this fusion, you can guide better your procedure, biopsy or treatment if you want to do ablation, if there is indication for that. This is another case. Once again, Doppler, B mode, and arterial. This is a pancreatic phase on CT, just to compare infiltration of the involvement, encasement of celiac trunk before our fine needle aspiration, and better if you want to perform an ablation of this lesion. Let me show you how it can be, once again, precise. Our synchronization, you can view flow inside superior mesenteric artery in this case with a fusion imaging with the CT, and you can also add contrast, and then you can have really a complete evaluation of the flow in the superior mesenteric artery involved, the celiac trunk involved. The lesion is here. This lesion is typically markedly hypo, ductal carcinoma. This is a very complete study for evaluation of our planning to plan our procedure. This is an MRI with together with ultrasound. Also in this case, you can see how the lesion is reachable in an easy way, and you can add contrast, as you can see here with this window. Coming back to a procedure, we are viewing now the needle inside this small ductal carcinoma. The main pancreatic duct is dilated. You can add Doppler to be sure that we are avoiding vessels. And then in this same case, you can use Doppler also to prove the presence of a needle. This is the artifact, of metal artifact with the needle that is perfectly inside, had to be there for our ablation. Perhaps more sophisticated, more complicated, all these procedure, the ablation one, I mean, have to be performed in the operating room, in the dedicated room for this interventional procedure. And you can see here fusion imaging. Also, we can try to simulate the ablation area that needs to stay perfectly inside the lesion. So before the procedure, just to know if the needle is open correctly to treat this kind of lesion. We published 2 papers on that. So 5 years of experience. This is the last paper they published in 2020. And just to coming to our conclusion, fusion imaging nowadays is easy because there is this automatic synchronization. This is very important. You can think to what you need to put together with ultrasound from one patient to another one, from one case to another one, because you can have fusion imaging with CT or MR, but why not with PET-CT? And you can use fusion imaging for biopsy, but better for treatment, because if you are skilled enough to perform biopsy with ultrasound and percutaneous approach, you can have 10 procedures, as I told you, in one morning. With the fusion, perhaps is more long, and so you will do not have the same performance. So, but for sure for treatment, yes, and in particular, speaking also about liver, I can tell you that our suggestion is the use of fusion for ACC recurrence, because you treat and retreat this patient, and so with CT you can have more panoramic view where the new nodules is, or the recurrence is, and for pancreatic cancer, because you improve your safety. for the procedure. Thank you.
Thank you very much, Mirko. There are two questions from the audience. So the first one is, how do you avoid the liver and stomach from injury during pancreatic biopsy?
Yes, the first, speaking about the liver, we never pass through the liver. So, and this is because with ultrasound, you can have the oblique approach to the pancreas from the epigastric or to the mesogastric region. So you can move down, and so caudocranially, you go directly to the pancreas. We never touch the liver. What about the stomach? This is, normally we can avoid the stomach, so by compressing with the probe, by performing a compression with the probe. However, and this is also true for the bowel, small bowel. However, if you go through the stomach, this is not really a problem. There is no any injury with a small needle if you go through the stomach to the pancreas. Also the bowel, also the duodenum can be trapped by using the percutaneous approach. We always need to avoid the colon. So the this for sure. And you need to be skilled enough to understand from the hair which one is the colon and which one is the small bowel and the gas. You know that this is possible. And let me say that if you want to start to perform an interventional procedure to the pancreas, first, as we heard for the previous presentation, first you need to be skilled enough to do ultrasound examination to the pancreas.
Yes, thank you very much. And the second question is, how do you manage patient breathing motion during biopsy?
This is once again because you need to see and to do this kind of procedure. There is no breath motion because you ask to the patient, please, when you're ready, please stop breathing, you go in and you go out. It is 5 seconds, 5 seconds.
Okay. Thank you very much, Mirko, and then thank you very much for taking the time, because we know you are busy with the MRI
Thank you
program.
to you, and see you soon. Thank you. Yes. Bye-bye.
Thank you very much, Mirko.